Maybe there is another. I'm not sure, but there is a possibility of the another.
One bunch.
Okay, looks like you're having fun in lab 2.
Stop it.
So sorry to interrupt you, Kevin. I'm not too sure whether you can hear me. Can you hear me?
Jack, I can hear you. Very soft, but yes, we can hear you. Welcome to a cath lab. Today we have an interesting CTO case on the RCA. We have a case that will be presenting the history. We have Dr. Okamura here with us. We will first present the history, then the angiogram, and show what we have done so far. We have a young 49-year-old male with history of dyslipidemia, diabetes, and hypertension. He is also a smoker. He suffered a non-STEMI at a young age in 2007, and at the time had single vessel disease in mid-LAD, and this was stented with a bare metal stent. 4 years later, he had suffered a non-STEMI, and there was further stenosis in the proximal LAD. There was a very late stent thrombosis of the mid-LAD stent, and both the proximal aspect of the stents and the distal aspect of the LAD stents were placed with bare metal stents. EF was at that time intact at 56%. He presented this year in August with unstable angina. Again, we found triple vessel disease. EF has dropped from normal to now 39%. There was an RCA CTO. We tried to do CTO PCI, but this was failed. And we treated the LAD in-stent restenosis with drug-eluting balloon and further stenting to the proximal circumflex. Next slide. This is the ECG is shown, no Q waves. And these were the blood investigations, creatinine being normal. HbA1c was very high. Next. This you can see the baseline angiogram. This is the RCA you can see with collaterals. This is the target for today's intervention. The interesting thing was that there is LAD stents for which the septal collaterals were under, and the challenging thing is actually to pass the retrograde wire beyond the stented segment. There was a failed antegrade attempt to the RCA PCI. Okay. Next. Okay, this was the calculated score with a JCTO score of 2. Okay, so today the intervention will be to the RCA CTO, and maybe I pass the time to Okamura to explain what he has done so far.
Okay. Thank you for giving me a chance to do the intervention in Singapore live. So will you show me the first image? Sorry. I just only inserted this is the 8th French 075 side 4 gut catheter, and the wire is advanced into the sinus node to stabilize the gut catheter, because relatively the RCA is vessel size is smaller, so that's why I didn't do any injection, because there are a little bit of injection, but I'm afraid of the dissection. So this case, this is an antegrade failure. So there was a wire perforation 4 months ago. So that's why I selected the primary retrograde approach. We'll go next image. So I checked the angiogram from the RCA side, but there is some stenosis around the septal channel just before the septal channel. DCB was already treated 4 months ago. So that's why I wanted to open the LAD side just before the septals, but before I advance the wire into the septal channel. The next, please. So this is a septal channel. Maybe the first one is a very promising one. The first septal channel, the right side, there will be a connection. But the main part is this is a crank. After the stent strut, maybe the wire should be going to just go to the right side. So next, please. So I just only advanced this is a C1 wire into the septal channel, septal channel to the left side. And I advance. This is a Corsair XS. This is a Corsair XS. I just bougied it and I advance the next one. Try to control the wire into the right side. This wire, single wire technique. But this is very difficult. I just only advance the mid one. So just why I changed the mind to change the microcatheter to the Sasuke. And Sasuke, the next place, I advance the Sasuke wire. This is a septal channel, but this is a mid one, not the intended one. So I advance the right side is I wanted to go. So that's why I changed this is a Sasuke. So I advance the next, another Sion wire into the more right side by using the OTW lumen of this double chamber catheter. So several attempts, I changed the very acute angle for the next guide wire. The guide wire was advanced into the intended route. There I did advance it, and I advanced the wire into the LAD. I pull back the mid one to the LAD side. Okay, so just now I opened because there was a stenosis just before the RCA. So that's why 3O balloon and 1 point, 5 millimeter balloon, I just only a cavity. And I advanced the Corsair XS, and I did a tip injection from here. So from tip injection, maybe the straight, but some crank is at the mid part of the RCA septal channel. So I couldn't clearly identify that's why, but I advanced this is a 403. 003 I advanced. But it was stopped around here. So I did a rotational angiography and to check it. This is aerial coda view. Maybe there will be some crank, but it's not clearly seen it. I also did a rotational angiography, but there was a crank. But maybe the aerial coda is much better. So that's why I did a wiring from the aerial coda. And maybe from some bending, maybe it was the straightened by the heart movement. Not this wire. This is maybe some small branch or something. So that's why the wire movement is no good. So that's why I checked it. I pull out the Corsair XS. Maybe my feeling is that this wire is going to the wrong way, right side around the mid part of the septal. So I pull back the wire and then reroute a little bit right side. And it was just passed. So this is a procedure I did just now.
So thank you, Professor. I think your strategy is quite clear cut. So just to re-summarize, fairly young man, but arterial path, 49 years old, multiple NSTEMI, fully controlled diabetes. Now the target vessel is a recently failed RCA CTO. From the panel, I just like to listen to our Southeast Asian colleagues first. Regards to approach, then I'll get the Japanese operators to feedback whether this is what will be recommended. Dr. Rajesh Shah, would you go straight to a retrograde attempt? Do you treat this medically? Would you re-attempt the antegrade approach? What would be your practice?
It's on. Yeah, well, I don't know how they did the antegrade approach and all that. I mean, I always use antegrade as my primary approach. Only if it fails, then we go to retrograde. So, yeah, but if it's already failed and we've seen it done, then I suppose, and this is not a straightforward retrograde because the retrograde channels are all through the stents. I think he did a marvelous job here using the Sasuke to then get the wire through, and that was really good, and we need to dilate that. Once we get up to here, is the Corsair in all the way already?
Corsair seems to have crossed the RCA.
Oh, the Corsair.
This is a Corsair is already.
Oh, right, okay. So then, yeah, then of course now we just put the wire proximally through the antegrade and see and try a reverse card at this point.
Okay.
Yes, yes.
Dr. Eugene Wu, Will you reattempt an integrate approach, or you do this as well?
Give me some wire.
I think
Sion
the
is XTR or something.
reattempt of an antigrade is quite difficult because the problem is ambiguity in the proximal part of the RCA.
Yes.
There are two ways you can overcome this ambiguity, of course. You can do antigrade IVUS guidance, or you can do retrograde. But if you do retrograde, you probably end up knuckling a retrograde wire to overcome the ambiguity. So I am of two minds. I think if you asked me 2 years ago, I would say use retrograde to overcome the ambiguity. But nowadays, and we have Okamura operating. He's the expert with antigrade IVUS. So if and the IVUS nowadays, you can just put down through the hole that you made with the Corsair. So I think nowadays, I probably would go antigrade IVUS and try to find from the side branch the puncture, the true lumen. And if I'm in the subintimal, then put an antigrade IVUS down there to see how far I'm subintimal, to see if I can wire true lumen. Not with the aim of getting a true lumen wire down the vessel to the true lumen, but the aim of getting a wire in the true lumen to remove the ambiguity.
Okay, so ambiguity is the issue. Dr. Nakamura, you have any tips and tricks? We agree with this. You think a pre-procedure CT angiogram is useful?
So actually, for the everyone, this is a bit good education for the everyone who doing a PCI. So actually, but I just want to say, this is exactly the case of the enjoying antegrade. Because at this stage, actually no one failed. No fun, actually for me. But anyway, this is the stage of us. So PCI, CTO PCI is very sure, and everyone can do it.
Okay, Dr. Ochai?
Yeah, so I think this case is a primary retrograde approach case.
Maybe
But I think Dr. Okamura is working in a very nice biplane room. Why you use a single plane?
Yeah. Just now I'm doing the septal channel manipulation. So that's why I wanted to do the rotational angiography or something. Sometimes but just now, we are started.
Okay, so you set up lateral view, huh?
Yes.
Yeah. So it's for septal channel tracking. It's operator's preference which to use, a rotational angiography or biplane. My favorite is biplane, but it's okay. Yeah.
Because this point is a very proximal part. There is a very ventilation just beyond the stent. So that's why I want to see the areocranial also. Proximal part, areocranial.
Yeah.
Then areocaudal. Then I want to do the rotation angiography. Areocaudal cranial is maybe a little bit difficult to do the biplane. But it's not a good. Maybe.
Yeah, and it's
sorry.
It's nice to make a very strong injection from antegrade to create dissection. For antegrade preparation. That's a joke. Thank you very much. Dr. Habara?
Yeah, so that's so this case is so I
Okay,
of course so I try to integrate at first, but so there is so good criteria from the so septal channel. So that's so if the so guide wire go to the so subintimal space, this is time to change to the so retrograde. That is my strategy for this case.
And give me a Sion.
Dr. Hiragashi, maybe you can give us some teaching points about the view if you use biplane. What is the best view for septal collaterals, and how do you decide? Does the J collateral score help?
If available, I recommend to use biplane system. Yes, rotational angiogram is I don't prefer. Yeah, so long time strong power injection is necessary. And
So areocaudal view.
Areocaudal view and LL view is my standard view. And this case is absolutely, I start with retrograde first because retry case and the distal target is very poor and ambiguous fibrous cap and so many factors. Yes, antegrade wiring is very difficult. Must be.
So your primary approach is retrograde.
So retrograde first. Retrograde.
I'm sure all the operators will have got to this stage and. What is your strategy now, Dr. Hiragashi, when you reach this stage? Is it going to be a reverse cut or are you going to try the primary wire?
Yeah. This case is probably reverse cut technique is most effective, I think. After this situation, next step is, of course, preparation of reverse cut. So he will soon start to integrate the wiring, and the target is clear. This wire is a good target for integrated wiring. And if go to the overlap position, next step is a reverse guard. That is a routine, routine reverse guard procedure.
Any of the other panelists will disagree with that? Is it going to be a straight reverse cut from here? Everyone agrees?
Yeah, so this case, so there was a perforation 4 months ago. So maybe just now the antegrade Corsair is around here. So maybe the 1.5 or 2 centimeter just the distal side, there was a wire perforation. So the entry point might be this area, but I'm not sure. So that's why I will do the tip injection from here. Maybe in Japan, we have a anti-all or navifocus IVUS to see the entrance point. But maybe I think that it's a little bit hard to see the puncture point by using the eagle eye or Boston IVUS. Boston IVUS there might be. But maybe from the running of the coronary artery, I think that the guide wire, the CTO entrance is just beyond the 1 centimeter distal part of the Corsair. That is a small bending point of the small branch. But I'm not sure. So give me a UB3 wire. But anyway,
I agree with you. And first, I'd like to try UB3 or some DAL 3-gram wire. But if not successful, we should do some funny things.
So, Woon, can you tell us what is the wires in both the antegrade and retrograde approach currently?
Just now, the retrograde is XTR wire. The antegrade is just now just Sion to deliver the Corsair. But because the proximal entrance of the location is not clear, so that's why I will try to advance the retrograde wire a little bit more to confirm, if possible, the entrance point of the CTO region.
So, Charles, please.
When will you consider to do retrograde knuckling? I mean, some people would just say that if you do knuckling, probably might be safer in the sense that you at least know where the artery's outline is going. But at the moment, you don't know whether it's one of those small, small vessel.
Usually, vessel course is unclear. Knuckle wiring is very effective. However, this situation is, vessel course is not so difficult to predict. So in this situation, knuckle wire is, I think, probably not necessary.
Yeah, we can see the calcification. So that's why around this part, we can see the root of the CTO. So that's why I advanced the retrogradely by using like a searching to pass through this area by using the XTR.
But still, do you continue retrograde XTR wiring?
Yes.
But I disagree. Already not necessary to continue that wiring.
Okay.
And,
so Dr. Ochai's, we have gone with UB3.
I try UB3 or Miracle Neo 3 for maybe 2 minutes.
2 minutes.
And if not successful, of course, we are partly confident about the vessel course. I use Gaia Next to maybe 2. And if the tip makes knuckling, just push.
Yes. So fundamentally, in this situation, most important point to select integrated guide wire is keep inside of vessel.
Yes.
So that is a most
if we
important
keep
point.
inside the vessel, intima or subintima is not a big problem.
Yes, exactly.
Yeah.
So I think if we allow it, we'll stay with Dr. Okamura a bit longer, because I think a lot of the audience is always more concerned about this part, what to do at this stage. before we move on to the second case. So we'll spend a bit more time watching and then discussing how this connection is created, whether it's going to be a cut, whether it's a primary reverse wiring, what are the techniques and tips and tricks.
Or if integrated wiring is difficult, we can inflate a big balloon at the proximal RCA, make artificial dissection, and make integrated knuckle wiring utilizing intentional dissection or intentional subintimal wiring.
Any of the other panel have any other suggestions?
Occlusion length is not so long, and now two wires are dancing. So in this case, we don't need to do very aggressive procedure.
So give me a Gaia, just a moment. Miles, yeah, counterclockwise. But maybe I try to do the precise guide wire control, but maybe the UV3 is a little bit difficult to do this 3D wiring. So give me Gaia third.
Gaia third.
Next.
Why do you select Gaia third?
Because I wanted to do the penetration. Just do this 3D wiring. The root is, we can see the root, but here is a classification.
Dr. Munawa and Dr. Wu, at this stage, do you have any wire preference for the retrograde wiring? Or?
Well, I think it's one after like XTA or XCR, then I do usually, Gaia 1, because I don't see any calcification there from the retrograde. If can further, then it's okay. But if not, then we are going from the antegrade and reverse card with.
Okay. Dr. Wu, do you have any?
Well, now I think there's no more ambiguity. We know exactly where we are. There's very high chance that both the antegrade and the retrograde wire are intraplaque at this moment. So the distance is perfect now to do reverse cut. So we only need to move a little bit from the antegrade wire, and then we put a balloon there. And then, of course, if you're going to use the retrograde wire to aim towards the end of the balloon, you want a Gaia wire. So probably a Gaia next to or something like that.
Okay. I think there are different ways to cut it here. Is there any use in using IVUS at this stage?
No, the side branch is small. And maybe I put IVUS after overlapping of both wires and after unsuccessful angio-based reverse cut for 5-10 minutes, I put IVUS. But we need the volcano to identify the wire position in this kind of case.
So,
Dr. Okamura's antegrade wire wants to knuckle.
Yeah, no.
Just push.
This is the guide wire shaft.
Just push.
Yeah.
But please feel free to do what you think.
I did a 3D wiring, but a little bit the shaft is behind, the tip is coming. So this is a clockwise rotation, but already the shaft is always behind. So maybe a little bit, just a drilling.
So I think everyone is pushing you towards a reverse cut, but
yeah. But there was a perforation 4 months ago around here, so that's why I just only I precisely wanted to do, because the other classification is here, maybe around here. So this is a little bit difficult inside the classification. Just now the wire shaft is the left side, and also the here. The wire shift here. So if you understand that this is a counterclockwise rotation, maybe you can do the 3D wiring. But just now a little bit. Okay. So anyway, cannot be get entered into the here. So give me a but just a moment. I will do a little bit from the rest. Give me a UV3. Difficult. I will do the conquest to do the get into the center part of the classification. But anyway. Get the risk of the perforation. UV3?
UV3.
So now UV3 for the retrograde wire?
Yes. Because
sorry,
the target is a little bit. I can maybe see, but it's not clear. So that's why it's better to advance the retrograde, if possible, a lot more.
Kevin, what is the antegrade wire?
Gaia side. But there was a perforation at that point 4 months ago.
So maybe in a while, we'll allow you to work on it for a bit while we switch over and look at Dr. Masaki's case. Is that okay, Dr. Okamura?
Yes.
We'll give you some time, maybe.
Yeah. Thank you.
3 minutes. So my co-chair says we'll give you 3 minutes.
Yeah, I want to confirm the achievement of UB3 in this case. So there should be some chunky calcium around the tip of retrograde wire. Now 2 wires, 2 systems are dancing, I guess. In both projection.
Can see the reflection of the UB3 is quite nice.
Actually. Okay. Give me a conquest.
Conquest now from the antegrade wire, is that correct?
Yes. Because that route is very clear. And I try to do this is a UB3. Yeah, one chance to check here is a Gaia. Sorry, just a minute. I have a Gaia.
I have a different idea to select antegrade wire. Conquest Pro is easy to go straight and easy to go outside. So in this situation, probably Miracle 12, such a kind of guide wire is more easy to stay inside and more controllable.
Or another option is to inflate a balloon at the proximal portion of RCA to fix corsair.
Yeah,
to increase
more strong back and forth to acquire.
And persist with the UG wire. Yeah. So actually, I thought it's so close. I would try a bit more with this Gaia wire.
Conquest. Yeah, I try to do the advanced, but it's a little bit difficult.
So you choose regular Conquest Pro or Conquest Pro 12?
12.
12.
Usually 12. Because I directed the guide wire tip to the target, but it didn't advance.
So since we're changing a wire out, and then now this is antegrade attempt to connect, another 3 minutes, Dr. Ochai?
Yeah. I want to see. I think Conquest Pro 12 can achieve overlap, longitudinal overlap of 2 wires. If not successful, maybe I think the best thing is to make an anchor balloon at the proximal RCA. It's in the main vessel of RCA, I mean, not side branch.
Chai, can I ask you what's the difference between Gaia 3rd and Conquest Pro 12? I mean,
Gaia Next 3rd is more controllable. And so the wire has some potential to follow up vessel course. And Conquest Pro 12 is anyway puncture wire. But as somebody told us, it frequently goes just straight. But it's a great wire to make a hole.
As long as inside the vessel. Yeah.
In this kind of case, pre-procedural CT is very informative.
Yes.
Maybe there should be some full moon calcium. We actually have the films from 2011 where the RCA was still patent. So we actually saw the full course of the RCA.
we don't have Gaia Next in Singapore.
No, not yet.
So, no, the normal Gaia we have, sometimes we get into trouble, like it's very stiff, like hard lesion. And when the tip got stuck there, and basically you can unravel the wire. So I think we don't tend to use Gaia in those situations.
I personally feel that when there is a little bit of this tortuosity and bend, I would prefer Gaia still to a Conquest wire here.
Yeah. This is some bend is here, so that's why.
Yes, already this Conquest Pro 12, no wax, I think.
Yeah.
So immediately I recommend to switch to another one.
Yes. Yes.
Any other tips and tricks from the other panel? So I gather that the problem here is directionality rather than support.
Okay.
The heavy calcification between two wires. In this kind of case, sometimes intimal connection is impossible, so we should create some sub-intimal space. But retrograde wire made some progress.
Yes. I switched to the advanced one because it's better to advance the antegrade wire. I did a very precise guide wire control, but the guide wire doesn't work. Yeah, as Dr. Igarashi mentioned. So that's why I switched to the retrograde guide wire advancement and do the reverse cut a little bit the more proximal part.
The retrograde wire should still be interplant. There's quite a good chance you can wire true to true.
Yes.
And use IVUS to check.
Yes. Yeah. That's
so it's cross actually.
It will pass, huh?
Yeah, there is a possibility. Okay.
So you can try rendezvous.
But is rendezvous easy with a Gaia wire? It's not so easy with Gaia wire.
Intracoronary rendezvous is always something fun.
Fun.
It's very accidental.
So
this is a very
2 minutes
accidental.
or so.
But we can enjoy 2 or 3 minutes to achieve rendezvous.
So I will explain. So this is just now the wire is here. So the front and back portion. So this means that this is a front and back portion. This means that a little bit counterclockwise is much better. But from here to the here, yeah, counterclockwise is much better. But just one try. Maybe it's very difficult to control the retrograde wire into here. Yeah. On the point.
If not, maybe a guide extension catheter would be easier here.
This is a UV3. So maybe it might be difficult. Yeah, just one try. Because
But UB3 made a great achievement. I think inside the intima, so we can change from UB3 to next to 2 or 3 to make more progress to smaller portion of RCA.
Okay, looks very good. I think we covered the technique here.
I want to do the,
Yeah. Dr. Okamura, I'm going to move to Dr. Hamakazaki's lab now.
Thank you.
Then we'll come back and follow up with what you have done later on.
Okay.
Thank you very much, both of you, Woon, as well as Dr. Okamura. Dr. Okamura, you want to update us a little bit on what we have? Is Aaron Wong in the audience?
Maybe. Store?
Hi, Jack. We were doing antegrade preparation. The antegrade wire was changed to Gaia. And we tried passing a 1.5 balloon, but there was a lot of resistance, not much support. And we placed a 1.5 balloon in the branch as an anchor. Even with the anchoring, couldn't deliver the 1.5 balloon down.
Give me an eagle eye, IVUS.
But now we seem to have some progress in the retrograde wiring.
So retrograde wire seemed to pass through?
Yes, that's right.
What is your retrograde wire?
Retrograde UB3.
UB3.
Yes, yes. I try to do the reverse cut as a CTO part, but maybe under the anchoring, the guide wire, and also a balloon could not pass through it. Will you show me the forward feedback, please?
So now the tip of retrograde UB3 is free.
Yes, yes, free.
That's
so maybe,
good.
yeah. So I want to confirm by IVUS. Yeah, maybe it's better to do the reverse cut around this 1 centimeter, just beyond the sinus node. But under the anchoring, the balloon could not pass through it. And the antegrade wire is maybe there's a possibility of the tip is outside or something.
Okay.
So that's why I advanced the retrograde wire around only the 1.5 millimeter balloon dilatation. Maybe the wire UB3 is going to the, yeah, this is free. So I want to check it by IVUS. Yeah, IVUS. Okay. Eagle eye is coming.
So while you set up the IVUS, Dr. Okamura, can you explain to us a strategy now that you have a free wire there? Once you confirm that it's intermal, what is your approach from here? How will you plan to externalize this wire? Rewire back to the guide extension or snare, or what is your usual approach?
Usual approach, maybe in this kind of situation, maybe a little bit pull back and I direct a little bit more. But maybe difficult guide extension is one choice. But the coronary is not a big one. But maybe I try to advance the wire into the guide catheter. But I didn't try to do it just now because I want to confirm the wire is inside the intima.
My favorite procedure is to advance, of course, first to confirm the position of retrograde UB3.
Yes.
And then push the UB3 deeply into the ascending aorta and try to pass through the CTO by retrograde gears. And if successful, I change the wire to RG3 and snare it by big end snare at the brachiocephalic artery. That's my favorite procedure. In 2019, I did 4 or 5 times.
Yeah, I totally agree because if I try to catch the retrograde wire around the aortic valve area, it is a little bit difficult. And also some complication might be occur. So I wanted to advance the wire into the distal aorta and catch the end snare, bigger end snare.
In order to use end snare, we should change retrograde wires. But if you use Sumitsuji snare, you can catch, but it's a short wire. But Sumitsuji snare can use.
I thought, Dr. Chai, your favorite is the 3-prong large snare.
Yes, the biggest snare. But it's a pull-through procedure, so we should change retrograde wire from this kind of CTO wire into RG3. Usually, retrograde microcatheter can pass through in this situation, maybe more than 95%. But in very few percent, retrograde microcatheter cannot pass.
Dr. Shah or Dr. Munawa, when you have this free wire, do you routinely use IVUS to check to make sure that it's intermal, or you are quite happy when this happens to just proceed?
It's quite, hard to answer because one thing that, of course, if I can, I have to see with the IVUS. But again, that's with plus IVUS, of course,
1 hour.
of course. And yes, I like to do with the snare. Of course, if I can use that, then it might be go to the externalization.
So, OP Van, can you switch to the IVUS on the main screen? Then you can share with us how do you gauge whether the wire is intermal? So
yeah, we can see 2 wires. So maybe I think it's okay. 2 wires. 1 wire is main course. Did you please record? The IVUS confirmed.
I think retrograde wire came into the vessel lumen, not at the orifice of RCA, but a little bit distal. So there's a possibility to advance it into the guide. But for such kind of procedure, we frequently use internal mammary instead of implants to achieve coaxial engagement at the RCA orifice. But I think the easiest way is to achieve retrograde crossing and to snare the RG3.
So one option is to change the guider. Yeah.
What is a retrograde microcatheter? Excess? Don't you try to advance beyond CTO entry point? This retrograde microcatheter?
Yeah, so one option is to really push this
Yes,
Gaia wire further
Yes,
up
yes,
and then try to cross.
That is usually most standard method, I think. And after passage of CT region and switch to the floppy wire.
Is it in or no? It's not.
So please keep guide cast. I want to advance the disc.
Instead of changing the guider, the other thing you can consider is to use a Godzilla or Roadrunner. I think just push it in just proximal to the conus branch.
Currently, are you trying to advance microcatheter?
Yes.
Oh, progressing. Yeah.
Yes. Yeah. This is gently. This is a Corsair excess. So that's why.
So this is the most common and standard and simple method, I think. If delivered until proximal to lumen, easily you can change to the floppy wire. The more easy to capture.
This is quite impressive because usually there's not much wire support. Yet the Corsair X.
If we put UB3 more deeply into ascending out support is
more supportive.
Yeah.
You will put the UB3 all the way across as far up the ascending aorta as possible? Or?
Yeah, if we just push, usually UB3 go to ascending aorta. It cannot penetrate aorta. It's impossible.
Okay. So maybe we'll spend another...
I suppose retrograde Corsair EX, XS made some progress.
Yes.
And approaching proximal cap.
So at this stage, there are a few approaches. I understand you can get the wire in, change out a wire, try to rewire back with another control wire, or change your RG3 and try to snare, or change the guider here to IM or RCA guider and see whether you can get more correct. Of course, guide extension is one possibility. So we're going to take a pause here, and we'll move towards a lecture. Yep, and then we'll get back to you, Dr. Okamura.
Yes.
Woon, maybe I think Dr. Okamura is concentrating. You can tell us where we are now. You can switch to the imaging. So you have externalized? Snack.
Jack, are you back with us?
Yes, we are.
Yeah.
Right.
So the retrograde system, we have changed to a routine over the wire balloon system. We've done some inflation. By manipulating the antegrade guide, we were able to direct the retrograde wire into the antegrade guide.
Okay, good.
By trapping the retrograde wire in the antegrade guide, we have actually delivered the regime inside the antegrade guide, and we're changing now to RG3 to externalize.
So you're externalizing the system now?
That's right.
Just now I'm doing.
So you did not need to snare the system, is that correct? You just...
we were about to.
Yes. I usually use the end snare, but we don't have it. End snare is... I am familiar with the end snare system, so but we don't have it in here.
I have an snare system in my room.
Sorry. Okay.
So we have to go to his hotel room to help you out, but
I'm very happy to send.
Okay, okay. So anyway, I will explain. So please back, please. So maybe it's a little bit hard to. So sorry. But anyway, UV3 is passed with. But I wanted to pass through the Corsair excess from retrograde. But it was a little bit difficult. And also there's some friction around the UV3 wire to advance more to the aortic area. So that's why I try to do the guide plus, guide ojira to catch it, but a little bit difficult because the margin is very small. So that's why I decided to pull out the UV3 wire as possible as I advance the Corsair excess. Then I advance the XTR into the same lumen to the aorta. And I further advance to the XTR to the more distal part. Then I advanced the Corsair excess, but maybe the Corsair excess couldn't pass it, and maybe I'm afraid of the damage of the tip. So that's why I changed the balloon. This is a OTW 148 centimeter longer balloon from septal to the retrograde. Then I opened it.
So for retrograde side, you used 100 centimeter guide or 90 centimeter guide?
This is a 100 centimeter.
100.
It was okay. It was okay.
But it's very nice to have a very long over-the-wire balloon. We sometimes forget it.
Yeah, it's I think at least 150 before you can, 145, 150 before you can reach.
But anyway, I advanced the, I'm a little,
Okay.
yeah. So I changed the shape of the retrograde wire into the Sion wire, and the Sion wire got into the antegrade guide catheter. Just now I'm doing the externalization. So yeah, I will advance it.
So I'm going to leave you here. This is just a nice time for us to see this maneuver. Very nice, Dr. Chan.
Yeah, so what is very important is to bring your own ensnare when you do procedures abroad.
Yes,
I always bring 2 pieces of biggest ensnare in my bag.
Okay, okay. Yeah.
Okay, but I think Dr. Okamura
Very nice and elegant procedure.
Yeah.
Congratulations.
Thank you.
Very nice, very nice. We'll come back to show the final result later on, Dr. Okamura. Hi, Woon, can you hear me?
Using the stents, we have put in 2 stents. Maybe we can show what we have done so far.
Deflate?
Yeah, deflated. Let's show flip back.
So you externalize with RG3 and...
Yes. This is just now the RG3. And yeah, will you show us the IVUS image? IVUS is already done, and all the lumen was intima. And I put the stent, deflate. And can you see the IVUS? IVUS is a very calcified region. Maybe the outer side. But anyway, so I found that these are very longest calcified regions. So that's why inflation. And mid part, proximal part is non-compliant valve is needed to open it. More than 20 atmosphere. This is a very tight region. And I put just 2 stents. And maybe finally I want to.
Distally is very small, the RCA. What stents are you
We show the 2.5, and the proximal part is 2.75. And I just now finalizing the deflate, 3O balloon for the proximal part. Okay, so I will take Cine, just gentle injection to small test to check. Okay, so store it, and a little bit. Yeah, it's okay, take Cine. Gentle injection. So,
very nice.
Yeah. Thank you. So maybe PDA branch, some plaque is here, but maybe it's okay.
Yeah, I think it's okay.
Okay. So I want to check the damage of the septal channel and also Yeah, we are finishing. So I will advance the...
The stent is to the ostium of the RCA?
Yes.
Yes. It's better to check the IVUS. Okay, so give me IVUS. I have a eagle eye. Ring down, sorry, just a moment. Ring down here, ring down. Again. Okay, thank you. And record. This is a PDA branch, and here is okay. Some plaque is here, but maybe it's okay.
Yeah, I think okay. No edge dissection looks okay.
Yes. And we are checking. This is a calcified region area. And I will pull out the pull back the catheter and to check the ostium. Okay, so just the ostium. Maybe
Very
it's
nice.
Okay.
You caught the ostium right there.
Really shows the proximal part. Maybe it's okay. A little bit distal, but still most of the part is covered. So we a little bit prove up. I will advance the Corsair XS to pull out the RG3 wire.
Yep. So this part is useful to protect the collateral channels.
Yeah. I just now. Okay. Yeah. That's right. That's fine. I will pull out the Corsair RG3 wire. And give me a Sion wire. Yeah, in case of the some damage of the septal channel, I will advance the CO wire.
So, Dr. Okamura, your case was very, very well done and a lot of teaching points. But I'm afraid I have to switch back to Dr. Hamazaki's lab.
Yes. Okay, thank you.
Yeah, but excellent. Congratulations. Very good results.
Thank you. Thank you.